Hello, this is a continuation of our lecture, and in this topic we'll be talking about the assessment of your eyes. So, let's focus on subjective data. Of course, in the nursing history, we need to ask the current health status. What will be included there is that we'll be asking what's the current perception of the patient problem. So for example, if your patient is having blindness, we need to determine how does the patient perceive this. Oftentimes, there are patients who have poor compliance or poor access to medical services that would say that it's just okay for them to have those kind of illness because they don't have money to spend for those. Okay, we also need to check for visual acuity. So visual acuity, we need to assess the near distance and the far distance. Also, we need to assess for the presence of blurred, double, and distorted vision. So you also need to know if your patient is having these signs and symptoms, when did the symptoms begin, and what was the trigger of these symptoms. We also need to check for pain. Okay, for pain, we need to check if it is sharp or dull pain, and then check if it is worse when blinking. Okay, pain that is worse when blinking is usually associated with our pink eye. So pink eye is another name for your conjunctivitis and your stye. Okay, we also need to know whether both eyes are experiencing signs and symptoms. Okay, so you have your unilateral and bilateral eye involvement. So this will help us determine whether what part of the eye is damaged. Okay, so recall that presence of lesions, okay, on a certain part of the eye would enable us to deduce whether the lesion is will be affecting the right visual field, the left visual field, or both. And then we need to check for the history of discharges. Okay, part of this is to ask for the color and consistency. Okay, once there is yellowish and then the consistency tends to be thick and then it's odorous, you would suspect that there is presence of infection, particularly your staphylococcus infection, which is common in our eyes. Then we need to know whether the onset is sudden or gradual. So later on, we will know diseases that there are sudden involvement or sudden changes in the vision of our patient. Duration, how long has it been? We also need to know if there is recurrence. Okay, for example, we will have patients wherein there are chronic changes, or let's say there are chronic cysts present on the eyelids. Okay, so there are cysts that tend to recur. And then you need to ask whether the patient has self-treated or not. Due to the availability, for example, of your eye drops in the market, there are several patients who have this tendency to self-treat, okay, or self-manage, especially if we're talking about your conjunctivitis, because oftentimes Filipinos would think that conjunctivitis is a common condition. Hence, their tendency is for them to self-manage. Then you need to determine the aggravating and mitigating circumstances or aggravating and mitigating factors. What do they do to relieve it? Sometimes there are patients who would say, I would apply warm compress so that the pain would be relieved. How does this affect the activities of daily living? Okay, so this will be part of your assessment up to the past health status. Now, for the family health status, you also need to determine the lifestyle of the family, and then if there is something or if there is a disorder that is running along the blood or the bloodlines. Okay, so for example, if you have patients with history of diabetes mellitus, you would trigger that one of the complications of your diabetes mellitus is your diabetic retinopathy. Okay, so in your diabetic retinopathy, there is also blurring of vision. Okay, and then you need to determine for the history of eye surgery. So in the family health status, you need to know whether there are family members with the same signs and symptoms. So especially if we're talking about color blindness, there is a very high familial predisposition when it comes to your color blindness. Okay, so lifestyle patterns, again, you need to be checking on what are the things that your patients are doing, because exposure to continuous light, for example, computer, would tend to damage the eyes of our patient. Okay, for example, if your patient is in the welding industry, you need to check if your patient is wearing the proper eye protection, because prolonged exposure to your welding would also possibly lead to dryness of your eyes and also irritates your eyes. Okay, so you need to make sure that your patients are wearing your protective eye equipment. Okay, so on the review of systems, you need to check whether the patient is experiencing other signs and symptoms. So a very particular disorder wherein it results to retinal or eye problems is your diabetes mellitus. So in the review of system, you might be seeing signs and symptoms of diabetes mellitus. Also, if there are hemorrhages in the eyes, you need to check for possibility of hypertension. Okay, so there is a possibility that there is very high pressure in the bloodstream, in the blood vessels, that it results to microvascular rupture. Okay, so you need to assess for hypertension. Now, one of our assessment is your visual acuity. So in visual acuity, we'll be assessing using your Snellen's test, the one which you're very familiar with, and then we also check for near vision testing and then color perception. Okay, so Snellen's test. So Snellen's test would offer us a result of 20/20. Okay, so it's an assessment of distance vision, whereas your near vision assessment is usually carried out within 12 to 14 inches. We'll discuss that in the succeeding slides. Whereas distance vision is carried out usually at 20 feet. Okay, so in Snellen, we ask our patient to read the lowest line possible, and the normal vision is at 20/20. It means that your patient can read in 20 feet what a normal person can read in 20 feet also. So, for example, if your patient would have 20/50, that would mean that your patient can read in 20 feet what a normal person or what a patient without eye defects would be able to read at 50 feet. So again, 20/50 would mean that your patient can read at 20 feet what a normal person without eye problem could read at 50 feet. Okay? So meaning, it's just like saying that your patient needs to step closer to that image for her to see the image, or your patient need to step closer to that alphabet for him to read the alphabet properly. Okay? So, a result of 20/100 will be indicative of legal blindness. So when I say legal blindness, it does not really mean that your patient is encountering all black. Okay, in fact, it would mean 20/100. So if your patient cannot see within 20 feet what many people will be able to see at 200 feet, so your patient is already considered to be legally blind. So if our patient is discovered to be legally blind, what will be our interventions? You need to orient your patient. Okay, you need to describe the surroundings to your patient. As much as possible, we try to promote independence. That's why it is not ideal for us to be moving things around, because our patients will be familiarizing this. Okay, so you can have guide dogs if you're talking about abroad, but here in the Philippines, you would usually see people using canes. Okay, so the use of canes. It is advisable that before you touch the patient, you need to talk. Okay, and when you are talking, make sure that the patient will not be anxious or will not be shocked by the way you approach him or her. Okay, so talking before touching. So that would orient the patient that there is somebody around, and then somebody might be touching or assessing him or her. Okay, when you are ambulating, it would be wise for you to ask the patient to hold your forearm. Okay, so by holding the forearm, this would ensure, this can ensure that you are a step ahead. Okay, you are a step ahead to your patient. Also, talk frequently. Okay, if your patient is awake, you need to talk frequently. Okay, especially if you're dealing with them in nursing homes. Why? What's the purpose of talking frequently? This will make them feel that they are not neglected. Okay, this will avoid feelings of neglect. And then when you are talking or doing activities, it should be relaxed and unhurried. Okay, because your patients are actually wondering and they are actually trying to follow if what are you doing to them. Okay, by the time that you are doing a procedure to them. So, relax, unhurried. Okay, you need to explain the procedure to your patient. As mentioned, you should not change the location of the objects. So, that would promote safety in the room. And then, do not rush to offer help. Okay, you usually need to assess, because some of the patients, especially who have acute blindness, have the tendency to try to do their things on their own. Okay, independence. And then, if they are offering gift, of course, you would not be giving gift which are having very nice colors. Okay, it is advisable that you be using gifts that would trigger other senses. So probably perfume to trigger your sense of smell. Okay, something that would trigger the sense of taste, so that not to increase the disappointment of the patient on the vision loss that she is experiencing. Now, since we are talking about the Snellen's chart, if you can see in the Snellen's chart, the topmost letter is the letter E. Okay, so if your patient cannot read the big E, so the next thing that you'll be doing is to do the CF. Okay, CF would stand for counting of your fingers. So what do? I would stand 5 feet, okay, and randomly 5 feet away from my patient, and then randomly, okay, show number of fingers. So if my patient could still not follow or could not see the number of fingers that I am showing, the next step is for me to move closer to my patient, okay, until either 1 foot away or my patient can correctly count the fingers. Okay, so I continue to move closer to the patient until he or she can see my fingers. With that being said, okay, for example, if you are at 3 feet and then your patient is able, okay, for example, your patient is already able to see and count correctly your fingers, okay, you need to revalidate that by 2 to 3 attempts, because sometimes your patient might just be doing guessing game. Okay, so again, if your patient could already see your fingers at 3 feet, that would be documented as CF, okay, /3 feet. That would mean the patient is unable to see using your Snellen's chart, but the patient is able to count, okay, or able to see at 3 feet. Okay, your patient is able to see at 3 feet. Okay, so this is an example of your Snellen's test. So again, your Snellen's test is a test for distant vision, and 2020 is the standard for normal vision. Okay, be careful. There are patients who are trying to memorize the contents of your Snellen's chart, but note that there are differences and variations also on the Snellen's chart. Now, near vision testing. So your near vision testing, we refer to this as your Rosenbaum pocket vision screener. Okay, sometimes they refer to this as your Rager's chart. Okay, so this is done by holding a cart with newsprint. Okay, in the clinical setting, especially in the Philippines, you would usually use a newspaper with different font sizes for us to assess for their near vision. Okay, but let's talk about your Rosenbaum. Your Rosenbaum, pocket vision screener is actually done by holding a card 12 to 14 inches in front of the eye, and then you're asking your patients to read. Okay, so usually would ask them to read from the topmost until the part wherein they are unable to see the letters. Okay, so color vision or color perception. So color perception, I think most of us are familiar of your Ishihara chart. So your Ishihara is named, I think, after the discoverer. So what you can see in the Ishihara chart is, of course, the patterns of colored dots. Okay, so of course, a test for color blindness. Your color blindness testing is very important because it would be able to help us assess for the activities of daily living. Okay, for example, there are these case studies wherein there are people who are trying to survive with color blindness without telling the society. So what are their tendency? Okay, the tendency is for them to drive, and then they try to memorize. Okay, they try to memorize what is the first light above on the traffic light, and then what's the second light, what's the third light. Okay, so that's how they would be working. Okay, now so we need to be careful to assess them in such a way that they should not be risking a lot about themselves. So red and green, okay, red and green color blindness is common. That would be an issue on traffic safety. Okay, if your patient also will be working as a commercial artist, photographer, airline pilot, okay, electrician, and then for example, seaman. Okay, so remember that these patients need colors. Okay, their colors are part of their work. Colors may be used to signal distress, and colors may be used to communicate. Okay, so in this line of profession, usually you would see that there are people not allowed. Okay, they are not allowed to enroll, or they are not allowed to work in this line of work, because knowing colors and recognizing colors properly could mean the life of your patient. Okay, so if your patient would be having color blindness, remember that our problem is cone. Okay, and that part of your eye is with the highest sensitivity, okay, or the highest concentration of your cone is referred to as your macula. Okay, so it has the densest cone concentration, hence it is the area of greatest sensitivity when it comes to your color blindness. Okay, so there are lenses that could help patients with color blindness. However, usually they are difficult to manage, and then they tend to be a congenital problem until and they are discovered until the patient would pick up wrong colors of substances that they are supposed to. Okay, so usually in elementary years, for example, wherein you would notice that instead of coloring something with red, they have difficulty to identify. So your nursing intervention for your patients with color blindness would be to offer labels. Okay, so for example, whether they are holding their ball pens or blank or whatever with colors, so you'd say you would label it with red or black. Okay, so for your patient to be cognizant of the colors. So next, you test for ocular movement. Okay, so in your ocular movement, recall the 6 cardinal positions of gaze. Your 6 cardinal positions of gaze will help us assess of your extraocular muscles. Okay, your corneal light reflex will also be helping us assess for your cranial nerves, and other than that, your muscles. So notice that if you can recall, it is your uh, it is your muscle which would induce your pupillary light reaction. By the way, just for us to differentiate your corneal light reflex and pupillary light reaction, okay, there is a difference between your cornea and your pupil. So go back to the anatomy and try to see the difference between the two. When I talk about pupillary constriction, so that's the time that if light is shown to the eyes of your patient's pupil would constrict. Okay, or it would decrease in size. When I talk about corneal light reflex, okay, this would mean that if I will shine or direct a light on the nose bridge of the patient, I will see the reflection of the light in equal or almost the same location in both eyes. Okay, so that is your corneal light reflex. That reflection class is actually from your cornea. So again, when I place, okay, or when I light at the nose bridge of my patient, the reflection on both eyes should be on the same location. Okay, it should be symmetric. Or else that would imply that there are problems on the structure of your cornea. Okay, we also assess the peripheral vision or the visual fields of your patient. So this will help us determine if where is the location of the lesion. Recall the picture that I have shown you with red and blue lines, okay, from the eyes going towards the brain. And then this will also help us determine whether our patient is at risk, okay, for approaching vehicles because they are unable to see at the peripheral vision. Okay, now doing your physical assessment, of course, on inspection, okay, we expect the following: that your patient would have a vision of 20/20, the eyes would appear symmetric without lesions. Okay, the conjunctiva is clear, although you will be seeing micro blood vessels there or the microvasculature. Other than that, your conjunctiva should appear to be clear. Okay, it's white, and then the other one, your pearl. Okay, so pupil is equally reactive, round, pupil is equally round, reactive to light and accommodation. Okay, then palpation. During palpation, you need to palpate for the lacrimal apparatus. Okay, you need to ensure that the lacrimal apparatus is indeed non-tender and without drainage. Okay, it should be non-tender and without drainage. Now, you evaluate your ocular fundus. So, when you are evaluating the ocular fundus, this could be done using your ophthalmoscope. And then, we need also to estimate the IOP, although in our setting, this is commonly done by the physician. So, take note, the device that is used to evaluate for your IOP is what we refer to as your tonometer. Okay, IOP, by the way, is your intraocular pressure. Okay, if we have ICP for the brain, we also have IOP for your eyes. So again, that would stand for intraocular pressure. And the equipment used to measure that is your tonometer. Now, class, this is an example of your ophthalmoscope. Okay, actually, you are looking at both the ophthalmoscope and otoscope. Okay, a familiar brand here, which is Welch Allen. Now, if you are doing the examination using your ophthalmoscope, you would see that the disc margins are sharp. Okay, so try to go back again to anatomy and see what is an optic disc. And then you have your retinal vessels. So normally, your retinal vessels would appear normal with no hemorrhage or spots. When we are visualizing using your ophthalmoscope, okay, usually class, it's the large vessels that you would see first. Okay, these large vessels are not actually your arteries. Your large vessels, which are clearly visible in the ophthalmoscope, are probably your veins. Okay, then you will have your smaller arteries. This is attributed due to the deep-seated location of your arteries. By the way, on your left is an ophthalmoscope and then your right is an otoscope. Okay, so don't wonder why they would almost look the same on the body, because class, what actually happens is that we can snap out this part, okay, here. Okay, by just twisting that part, you can remove the ophthalmoscope and then change it with the end of your otoscope. So yes, as the term implies, otoscope, that is usually used when you are examining your ears. Not usually, but it is intended to examine your ears. Next, diagnostic studies. So there are several diagnostic studies that can be done for our patient. Laboratories, direct and indirect ophthalmoscopy, you have your CT scan, ultrasound, color vision testing. You also have your refraction test, then your tonometry. Okay? Other than that, you have your corneal staining, slit lamp examination, MRI, ERG or electroretinography, then you have your perimetry testing, then you have your Amsler grid. Okay, so class, usually when I'm talking about laboratory, the usual test done for eye procedures or eye-related disorders is your culture and sensitivity. Okay, especially for those with recurring stye. So the tendency is that we order for culture and sensitivity. Okay, other than that, we might be evaluating also for diabetes mellitus, which is crucial also when your patient is developing blurring of vision. Okay. Now, this is your direct ophthalmoscopy. So when I say direct ophthalmoscopy, of course, you are using the ophthalmoscope. So class, an ophthalmoscope is an handheld instrument. Okay, there is a plus and the minus to maximize the lens. And then notice that you are holding the ophthalmoscope with your right hand to examine the right hand of your patient. Okay, so this will help ensure that our face will not be against the face also of your patient. Okay, so again, if it will be your left hand, or if you will be examining the left eye, you should be holding the ophthalmoscope also using your left hand. Okay, plus this would also, this position would also allow for clear visualization of your eye contents. So, when your patient will be having the ophthalmoscopic exam, one thing that we check is your red eye reflex. So, during the checking of your red eye reflex, okay, or during the ophthalmoscopic examination, it would be best that the room will be darkened. Okay, so this will allow for clear visualization. Then, you have your, when you are standing with your patient, okay, to do the eye examination, you should be at the same level with the eye of your patient. Okay, that's to promote comfort on our part as your healthcare professionals. Then you have your fundus examination. So when we are examining the fundus of the eye, again, the blood vessels would be seen first. And then the vein would appear bigger compared to your arteries. And then, we do not expect that there will be lesions. We do not expect that there will be hemorrhages. Talking about your indirect ophthalmoscopy. So your indirect ophthalmoscopy works in the same principle as your direct ophthalmoscope. However, in indirect ophthalmoscopy, so notice that the clinician here, or the optometrist, or the ophthalmologist, I mean, would examine the retina using a device which is worn on the head. Okay, so this allows for the larger areas of the retina to be magnified, and then you need to inform your patient that this produces a bright and intense light. Okay, so its purpose is the same as that of your direct ophthalmoscopy. Then we have your slit lamp examination. Slit lamp examination is done using binoculars, which are mounted on a table, and this would allow for 10 to 40 times magnification. Okay, this is done to evaluate your cataract evaluation. Okay, so the previous ophthalmoscopes could also be used to evaluate for your cataract. However, for this one, in slit lamp examination, we are evaluating for cataract through angulation. So we are differing the angles of the light, or the ophthalmologist will be differing the angles of the light for him or her to see the cataract of the patient. Then we have your tonometry. So when I talk about your tonometry is measured or the measurement of our intraocular pressure. So again, be reminded that your intraocular pressure is related to the presence of your aqueous humor. Okay, so recall that your aqueous humor could be found on the anterior chamber and the posterior chamber of the anterior cavity of your eye. So recall also that it is the ciliary body that produces your aqueous humor. So class, we need to be reminded that the normal IOP of our patient is less than 21. Okay, more than that, your patient may be already having glaucoma. Okay, so there may be problem in drainage, there may be overproduction of your aqueous humor. So these are two possible equipment that can be used also for your tonometry. So you have your diaton transpalpebral tonometer, and then you also have your ocular tonometer. Although this is non-invasive, it may offer some discomfort to your patient because the device will be touching the cornea of our patient. Then we have your fluorescent angiography, and then you also have your indocyanine green angiography. So these two angiographies, no? So when I say angiography, this would visualize the bloodstream. So in your fluorescein angiography, it is a fluorescent dye which is injected into the bloodstream. So the purpose of the dye is to highlight the blood vessels in the back of the eye so they can be photographed. In your endocyanine green angiography, so your ICG is the dye which is being used here. It would examine the blood flow to your choroid. So your choroid is the layer of blood vessels which lies underneath the retina. Okay, so this is usually done if your patient has some unidentified cause of blindness. So for us to check whether it is the blood flow that is affecting it. Okay, so you have your endocyanine, so which is attracted to your choroid. Then you have your electroretinogram. So electroretinogram is a diagnostic test that measures the electrical activity of your retina in response to your light stimulus. So this would determine if the problem is internal to the eye, or is it the eye, or is it the communication of the sensory signals from the eye going towards the brain. So in which meaning the problem is your optic nerve and not your retina. Then you have your Amsler grid. So you have here the comparison of how a normal person would see an Amsler grid, and then how would a person with MD or macular degeneration would see your Amsler grid. Okay, so this is an assessment for macular problems and macular degeneration in particular. One of our instruction on our patient is that they will be starting at a central fixation spot on the grid and report any distortion on the squares of the grid itself, which would indicate your macular degeneration, a problem on central vision. Then you also have your retinal dye injection. So this would determine also the proper circulation in the retinal vessels in the eye. So the dye would be injected in a vein in the arm, and then a rapid series of photographs will be taken. It's as if you're taking CT scan with contrast when we are talking about the brain. But in this case, you're taking photographs of your eye. So among other things, this test can detect the problem such as a block in your blood vessels, okay, decreased blood flow, and then your tumors. So you might be wondering as to how to do ophthalmoscopic examination in times like this, the pandemic. So there are already infection control protocols that are being practiced. Okay, so as you can see, there is a barrier here that would protect the examiner from that of the patient. Our next topic will be about correctable refractive disorders. Okay, already the disorders in your eyes. Thank you for your attention.